This was stable, it became unstable, and it returned back to the stable state. So, depolarization and repolarization movement mean changes. Those are the words keep on conducting. And once this happens, the cell has returned to the status where it can receive another signal. It is now capable of receiving another signal. What I'm describing here, taking the whole time to talk, happens in microseconds. Do you understand?
Yes, sir.
It may be difficult to believe, but just believe me that it happens. It happens in microseconds.
Okay.
And that is what keeps the conduction going on. Once it has repolarized, it can even receive again, and the whole cycle will keep on going and going and going again. So sodium will rush in and cause depolarization. When depolarization takes place, it will activate the sodium-potassium pump to open the gates for more sodium to move out and less of potassium to come in, so that it will restore the previous balance. Balance is restored, we say repolarization has taken place. That is to say that, at that point, the cell has become again more negative inside, more positive outside at negative 70 millivolts. Do you understand?
Yes, sir.
Okay, now, sometimes too much of potassium will leave. Now, we said here that potassium will be moving outside. If too much of sodium or potassium leaves a cell, it will create a condition called hyperpolarization. Now, depolarization and hyperpolarization are the two stages that brings about electrical transmission. Repolarization and polar state doesn't cause a change. But if a cell becomes depolarized, it means that that cell can actually be observed in terms of pharmacological changes. Or you may notice one particular protein is being produced more than, so that you can see the change of interest. So if too much of potassium moves, you will have what is called hyperpolarization. So if there is hyperpolarization, then what will happen is, again, that pump we have docked here is the one that will be even activated the more, so that it will return. I am mentioning these terms because as you are reading your pharmacology textbook, you are going to see terms like polar, depolarization, hyperpolarization, and repolarization, and all those stuff. And transmission and all this stuff, right?
Yes.
Yes, sir.
Kuwatin di yana fa sofo sinu pujo. Okay. I'm Mr. Gomaja. Go now and now one person first. Now and now one. That's your Maruga Kara watching.
So let me just go go through what we have said in a straight line. At the axon terminal here, you will receive a neuron will receive a signal from elsewhere. We're just selecting one neuron. This might have happened elsewhere, or it may even be an external stimuli. Maybe you touch a hot object, right?
Yes.
Or there is something, a mosquito will bite you, or something. And the signal will get to the nerves endings. And if it comes here and is strong enough, it will trigger the opening, because already, mind you, it is only the cell that is at negative 70 millivolts that is capable of responding to a new arriving stimulus, right? So when you say the cell is at a resting potential. So at resting potential, it means the cell is capable of new impulse coming in and it will be able to respond, right? At the resting potential, there is more electropositive outside and inside. Overall, the cell is at balance at that status. Anything that will upset that thing, the body will have to do a certain work to restore it to the resting potential again. So when the impulse enters here, it will trigger the sodium channels first to open. When the sodium channels at the cell membrane opens, it will allow influx of sodium ions. The sodium ions will rush in significantly and thereby change the negative nature of the interior of the cell. When that happens, it will trigger the sodium-potassium pump to restore that imbalance. At that point, you say, when it was at rest, you say it has two distinguishable poles, positive and negative. So you can say it is at the polar status. But when new positive cells, that means ions, enter in, the cell will become depolarized. And it will quickly activate sodium-potassium pump. When the sodium-potassium pump is activated, it will open both the sodium channels and the potassium channels simultaneously. This is the only condition where the two channels opens at the same time, right? So when it opens, three molecules, at this point, there is more sodium inside, and the attempt is to actually remove the excess sodium so that it will return it to up toward the resting potential. So what happens here is three molecules of sodium moves out of the cell, while two potassium moves in. Overall, 3 is moving, 2 is replacing back, which means as if only one that is going out steadily. Is it not true? So when that will happen, you cannot say that that cell has become repolarized. It has restored the lost polarity. So it has been repolarized. A situation will happen that excess of sodium will go out even more than what will cause depolarization. So when that happens, you have the cell to be even hyperpolarized. So the state of hyperpolarization or depolarization causes another set of cells to even return. When it returns back to it is ready to receive the signal again. And that is how it will keep on conducting. So as I said before, the lengthy explanation happens in microseconds. So one cell here will just go through the cycle within a microsecond. It will come back to the resting potential and it will be ready to receive again. While the impulse, it will pass to the next cell. The next cell will react and pass to the next cell until the information will reach the axonal terminal. When it reaches the axonal terminal, then the calcium we're talking about the other time in neuronal transmission will now initiate another concept which we explained before, right?
Yes.
So I think with this, you should be able to explain what happened right from the axon to the terminal here and crosses the synapse and comes down to the neuromuscular junction.
Yes, sir.
Any question? So as we explained before, you know that this is not touching, so transmission is the one that will take place there. These two concepts are very good questionable areas. You should be able to explain it. Any question before we move? Yes.
I learned in the scientific tissue that depolarization is caused by sodium influx, while repolarization is caused by sodium efflux. So how can we understand the meaning of that in this context?
Come again.
Depolarization is caused by sodium influx, and then sodium is coming to the cell. Repolarization is caused by potassium efflux, and then potassium is going out.
We explained all those things here. This efflux is moving out. Efflux is moving out. I said when this thing is balanced, or not, the balance here is not absolute balance, but it's relative. When it is balanced, it means there is more sodium here at any point in time. And there is more, there's more is coming in is influx. If this one is moving out, it's efflux. So the movement of this outside depolarization, while this coming in is responsible for depolarization. So the movement of potassium outside is the one that produces a more significant effect. And that's why the two of them are pictured here. We have two other things that we need here before we move into the drugs of the autonomic nervous system. We need to understand more about cholinergic receptors at this cholinergic agonists that produces their effect in the autonomic nervous system. Let us look at the receptors first. Cholinergic receptors. From the lectures, from our previous discussions, you'll be able to identify so far that when we talk about the autonomic nervous system, we talk about nicotinic receptors and we have muscarinic receptors. The nicotinic receptors are quite small, so let us start discussing the muscarinic receptors. Here you may need to go back and revise our notes, our lectures in the first semester. It will help you a lot. Let's talk about receptors. First, I usually don't like to rush these aspects so that you can, once you understand it, you can apply it anytime. start with the muscarinic receptors. They are called muscarinic receptors because they were first found to respond to muscarine. Muscarine is a steroid that was derived from a mushroom-derived steroid. Is the molecule, the chemical is found abundantly in mushroom. It can be found in other plants, but the first was isolated from mushroom. And it was found to stimulate the autonomic nervous system. Subsequently, it has been fully characterized. So far, about 5 types of muscarinic receptors: muscarine M1, M2, M3, up to M5. But at this level, 1 to 3 are fully studied. Different types of muscarinic receptors divided into 5: M1, M2, M3, M4, and M5. As I said, for the purpose of our lecture here, most of our drugs we are going to consider act more on either M1, M2, or M3. Those muscarinic subtypes are divided throughout the body. M1 is very much related to M3. Right. So as we go on, we'll be able to see where M1 is more, where M2 is more, and M3. But what I want us to understand is muscarinic receptors belong to the class of receptors called G protein coupled receptors. G coupled protein receptors. Usually, they are found on the membrane of a cell. And if they have 7 transmembranes, 7 structures, like this: 1, 2, 3, 4, 5, 6, 7. If you see in the textbook, you usually see as if there are small rods, 7 of them, and they are linked together continuously like this. They are coupled to proteins that help them to respond. So basically, all types of muscarinic receptors are G protein coupled receptors. When you are reading the book, you still see different types of G proteins. So the easiest way to understand the types of G proteins, they are usually numbered into GI, GS, GQ, and GO. Those designations are just to help us understand the different type of G proteins. Take the subscripts I, S, Q, and O to be different, like let me liken it to switches of the same G protein. And there are different types of them. So we'll look at it. So G proteins is actually composed of 3 subunits: alpha, beta, and gamma subunits. So when a ligand could be either the muscarine or any other drug that is capable of binding to this receptor. You call it a ligand. Now, as I said, it is composed of 3 active units. Unit 1 is called alpha. Another one is called what? Beta, and then you have gamma unit. But they are usually fused together. If you look in the textbook, they are labeled. Once a ligand attaches to muscarinic receptor, it will cause the alpha unit to dissociate, to separate, and it is the alpha unit that will go and be producing the pharmacological effect that we are going to look at later. So muscarinic receptors or G receptors are divided into 4: GI, GS, GQ, and G0. So let us take them one by one. What is the GI? No, let's start with GS. GS means stimulation. Those are the G-coupled receptors that has the ability to stimulate adenylyl cyclase. We studied adenylyl cyclase in the first semester.
Yes.
Yes? So if a drug is able to attach to a G protein receptor and is able to activate adenylyl cyclase, that will not give rise to accumulation of cyclic AMP, adenosine monophosphate. That receptor is described as GS, G stimulation. Do you understand?
Yes.
That is just what you need to know about GI. It is what it is able to do that will make you understand that, oh, this is a GI, because it is able to stimulate adenylyl what? Cyclase. Usually, when adenylyl cyclase is stimulated if a drug stimulates a receptor, it will activate adenylyl cyclase. Adenylyl cyclase will non-convert adenosine triphosphate to cyclic adenosine monophosphate, CAMP. CAMP in turn activates protein kinase, and it is the protein kinase that will now be able to cause cellular response. So, but what will make you distinguish any of this is because it is able to stimulate adenylyl cyclase. Finish.
I see the protein kinase.
The
Protein kinase.
protein kinase. I say it is the protein kinase that is responsible for the observed pharmacological action. It will either cause contraction to occur, cause the release of a particular hormone. There are different activities that you will see. You understand? So GS simply means that particular receptor activation produces its effect on stimulation of adenylyl cyclase. GI simply means inhibition. We can say that GI actually does the opposite of GS. While GS stimulates adenylyl cyclase, GI inhibits adenylyl cyclase. While GS stimulates the concentration of CAMP, cyclic adenosine monophosphate, if it is a GS, it will result to decrease CAMP, cyclic adenosine monophosphate. And in turn, it will also decrease the activity of protein kinase. So you can see it is directly opposite what the GS can do. But before, let me give you some of the examples of the cells that are actually, of the receptors that actually has GS stimulatory effect, like beta-1 receptor. You will find beta-1 commonly in the heart. Stimulation of beta receptors will increase heart rate And that is why beta antagonists are used in the control of blood pressure. Examples of beta antagonists include drugs like atenolol. You know atenolol?
Yes, sir.
Yes. So you can go and look them up. B2 is also GS. Beta 2 receptors are also GS type of receptors. They are commonly found in the bronchioles. Stimulation of B2 can cause bronchial dilation. Example here you have salbutamol. You know salbutamol is used in the treatment of asthma.
Yes, sir.
Asthma is characterized by closure of the airways. So when you stimulate the bronchial tree, it will cause the expansion, the dilation of the bronchioles, and it will now make the asthmatic patient to breathe normal, right?
Yes, sir.
So it is actually achieved by stimulation of GS receptors in the bronchioles.
Yes, sir.
So the GI is commonly found in the alpha-1 receptors. We are going to study all those the drugs, classes of drugs that act on beta-1, beta-2, alpha-1. We are going to study them later on. So you have alpha-1. Alpha-1 receptors are commonly found in the blood veins. Even it is also in the heart, but they are more common on the vasculature. And the moon receptors, we are going to study about moon receptors, usually abbreviated as this symbol, moon receptors. As we are going to study analgesia, you know, you have moon receptors, you have kappa receptors. When we study analgesia, narcotic analgesics, they are able to bind to moon receptors and then reduce pain transmission. There are GI receptors. Very important point. GI does not necessarily mean everything about the cell will decrease. I want us to understand that very well. So we say it is opposite of the stimulation, but it doesn't mean you interpret it literally to mean that everything has decreased the activity in the body. No, but it only means that the effect on adenylyl cyclase is stimulatory or inhibitory. But in terms of pharmacological action, you will notice that even when adenylyl cyclase is inhibited, it may cause a response in pharmacological action that can be noticeable. So don't just take it that it is reduction, and it means that when you take such a drug, there will be reduction of activity in the body. No, it doesn't mean so. So briefly we are able to explain GS and GI. What is the next one? GQ. If you remember, just listen first. If you remember our first semester lectures, we were talking about activation of phospholipase C. When phospholipase C was activated, it will cause the production of inositol 1,4,5 triphosphate and diacylglycerol.
Yes, sir.
Right?
Yes.
Any drug that is capable of stimulation or activating phospholipase C is described as GQ. GQ describe receptors whose activation result in the production of phospholipase C. And I said before, production of phospholipase C in the cell membrane will trigger the production of inositol 1,4,5 triphosphate as a second messenger. It will also trigger the production of another second messenger, diacylglycerol. Right?
Yes.
The two have their distinct action in the body that will end up producing a desired pharmacological effect. So here you can say a molecule receptor is GQ if its activation produces phospholipase C. I think it's easy to understand.
Yes.
GS stimulate adenylate cyclase. GI inhibit adenylate cyclase. While GQ has effect on what? Phospholipase C. So just go back and reverse. What does activation of phospholipase C? What does it happen? It will produce two messengers. Second messenger. The first messenger is actually the drug. That is why that one is called second messenger, right?
Yes.
The first messenger is either the muscarine or the drug that is causing effect on the receptor to produce phospholipase C. So when phospholipase C is activated, it will produce inositol 3,4,5 triphosphate and diacylglycerol. These two, they also have their pathway. The inositol pathway will cause phosphorylation of different proteins and it will change their behavior. Diacylglycerol is always able to activate calcium, and calcium movement into the cell may cause a lot of things. It will cause contraction of the cell, it will cause even the fusion of our nucleus, the neurotransmitters. They are actually affected by the diacylglycerol as we look at. So GQ simply means the muscarinic receptors that activate phospholipase C. Now, the last one is what? GO. GO functionally is similar to GI, but the O refers to others. Just others. You know, they were able to classify distinctively three. Anyone that is not stimulating adenylate cyclase, anyone that is not inhibiting adenylate cyclase, anyone that is not acting through lipase, phospholipase C, is regarded as GO, others. Do you understand?
Yes.
Yes. But generally, GO is very important in neuronal signaling. Neuronal signaling. It activates the influx of calcium ions, as we saw, where the entry of calcium ion is able to cause the fusion of the neuron with the vesicle, and subsequently the release of the neurotransmitter in that vesicle into the synaptic cleft. It is acted upon by GO, right?
Yes.
It is also responsible for opening of calcium channels. Calcium channels we were talking about in the conduction around the axon. The opening of those channels is actually the responsibility of GO. So they are activated by GO. Those channels are muscarinic channels and are GO muscarinic transmitters, muscarinic receptors. So as I said, the release of neurotransmitter is also controlled by GO. So in essence, GO receptors are more concerned with neuronal transmission. Do you understand?
Yes.
They are concerned about neuronal transmission. So if we put all the three together, the four together, in summary, GS will increase CAM. Do you understand?
Yes.
GI will do what? Will decrease CAM because they are going to inhibit adenylate what? Cyclase. GQ, one, it will increase calcium ion movement because or let me just say it acts through phospholipase C, which will produce 2 second messengers, inositol and what? Diacylglycerol. Both of them will act and increase calcium release, and they are known for that. While GO are concerned with the transmission of the neurons. Mostly they are concerned with transmission of the neuron. So when we are talking, if you are reading your book and you are seeing GI, GS, you just know what that type of receptor is capable of doing, right? Another type of autonomic receptor that is very important and we'll be mentioning is nicotinic receptor. Before I move to nicotinic receptor, let me mention that both nicotine, which is from tobacco, right? Yes. And muscarine, which is from mushroom, they can activate the 2 receptors. The only difference is in muscarinic receptors, the affinity is more on muscarine and little on nicotine. But both of them can activate it, right? When you come to nicotinic receptor, they are called nicotinic receptor because it has a very strong binding and stimulatory effect with nicotine. But that doesn't mean it's only that can stimulate or act on nicotinic receptors. Other molecules like muscarine can also do the same, although very minimal. Acetylcholine can act on nicotinic receptors, can act on muscarinic receptors. And as we go into the details of the drug categories, you will see that many drugs are also able to act on nicotinic receptors just like nicotine. And many drugs will be able to act on nicotinic receptors just like muscarine is doing. So nicotinic receptors is ligand, you call it ligand gated. Ligand gated receptors. The activation of nicotine receptors generally allow the influx of sodium and exflux of potassium. So if you see anywhere that sodium is said to be coming into a cell, or anywhere that potassium is leaving a cell, that is the action of nicotinic receptors. Nicotinic receptors have been activated. They produce rapid movement, causing depolarization. Nicotinic receptors, as I said before, they are commonly found along the skeletal, the joints of neurons and muscle, which is commonly called neuromuscular junction. They are also found at the autonomic ganglia, which we have studied before. All of them have nicotinic receptors. They are also found at the adrenal medulla, where adrenaline and the release of adrenaline and all those have nicotinic receptors. They are also present in high concentration in the central nervous system. There are 2 major subtypes of nicotinic receptors. The ones that are present and acting at the muscle neuron junction, which is neuromuscular junction, are usually labeled as NM receptors, while the ones that are commonly only at the neuron, you will see in your book, you have N, small n receptors. So this subtype is only telling you where you predominantly found them. On the NM receptors means they are predominantly at the neuromuscular junction, while the NM receptors are the neuron itself. Do you understand? Which means that you can have high concentration of these at the somatic nervous system. Do you understand?
Yes.
And you also found it at some other parasympathetic nervous system, as we have just mentioned. And as I said, muscarinic receptors have 7 transmembrane structures. It has 1, 2, 3, 4, 5, 6, 7, and you have a membrane going across it, and they are connected like this. If you see the structure, you will see it. But when you come to nicotinic receptors, it has about 5 pentameric parts. You know, you have something, it will be like this. You have, it will be like this. You have, if you do not have alpha, beta, gamma, delta, you have something round like this, and you see a hole. Stimulation of the receptor will now allow sodium to rush into the cell and allow potassium to rush outside the cell. So it controls the movement of both sodium and potassium ions. You should look for a way to see the structure and not to learn to draw like an artist, but you should be able to sketch it to give you a good understanding. So as I said, nicotinic receptors are primarily responsible for depolarization, the one we described in axonal conduction. So depolarization causes, number 1, it will cause skeletal muscle contraction. When you say depolarization has taken place, any of these actions may be observed. It may be muscle contraction, it may be autonomic ganglion transmission, it may be adrenal medulla secretion, it may be neuronal excitation. Any of these actions may be observed, and they are directly related to nicotinic receptors. So these 2 receptors, we are going to mention them a lot in autonomic nervous system. Very soon, it's expected us to move into the drugs, autonomic nervous system drug. But before we go into the autonomic nervous system drug, we'll look at the brief chemistry. There is an exciting chemistry about cholinergic drugs, which we are going to consider. The chemistry of cholinergic drugs. So as we say, autonomic nervous system drugs. We're going to go gradually. Drugs that are used in the autonomic nervous system are divided into 2. Drugs that are commonly used in the autonomic nervous system are divided into 2, based on the receptor type involved in their mechanism. Do you understand?
Yes.
The division of this drug is based on which receptor type that is involved. So we have 2 types. One, we have cholinergic receptors. Cholinergic drug, and we have adrenergic drug. Cholinergic from acetylcholine, adrenergic from adrenaline. Just like we studied before now.
Yes,
sir. So we have cholinergic receptors. They activate or inhibit by acetylcholine. And you have adrenergic receptors. So if any drug, the mechanism of that drug can be explained based on the action of acetylcholine receptors, we call such drug adrenergic drug. If it is classified based on the action on adrenaline related receptors. They are called adrenergic drugs. We are not going to go into adrenergic drugs now. We are moving into what? Cholinergic drugs. And before we go, as we go into cholinergic drugs, we'll look at the chemistry of cholinergic drugs. And under that, we are not going to go the detail of pharmaceutical chemistry that will be handled in fine chem. But what we are going to look at here, we are going to consider structural activity relationship. How changes structural activity relationship, SAR, is concerned with how manipulation, changing the chemical structure of a drug, how does it affect the pharmacology of that drug? Do you understand? Yes. How changes in the chemical structure of an existing drug, how does it affect the final pharmacology of the drug? That is what we are going to look at, the structural activity relationship of cholinergic drugs before we discuss the individual drugs in that class. So cholinergic drugs refers to anything that involves acetylcholine. When you say cholinergic drug, you are talking about drugs bearing in mind the beginning or the effect of acetylcholine as the prototype. That means one simple way of learning drugs is drugs are so plenty that you cannot, for the purpose of training, you cannot even finish reading all the drugs before you graduate in 6 years. You will not finish. The simple way is every drug, every family of drug has a representative drug. If you are reading a reference material like Endox, it is clearly stated there. In every class, there is one particular drug. It may not be exactly like all the other drugs in that family, but know about that drug alone will help you write anything, even if it's not 100% the same. It will represent the other members of that family. And if you adopt that method, it will help you a lot. So when we say a cholinergic drug, we are talking about drug in relation to what? Acetylcholine. That is the synthesis, the storage, the release, the receptors to act upon, metabolisms, and any other thing about it. Cholinergic drugs are also divided into two. You have cholinergic agonists and cholinergic what? Antagonists. Cholinergic agonists are the drugs that behave or act the same way as if it is acetylcholine. So when you understand the mechanism of action of acetylcholine and a drug is producing similar effect observed with acetylcholine, that drug is said to be a cholinergic agonist. But if it is opposing that, it is said to be antagonist. So let us look at we'll start the SAR by studying the structure, because we say cholinergic drugs relate to acetylcholine, and therefore our study of the chemistry of this drug will have to understand the chemistry of acetylcholine and what will happen if you change things on the acetylcholine. What will happen? First of all, acetylcholine structure has one important first structure that is very important on acetylcholine. Acetylcholine is one. You have the positively charged nitrogen molecule that is attached with 3 methyl groups. So you have this, this is the nitrogen, and it has CH3, it has CH3, it has CH3. This is very, very important for activity because the receptor is negatively charged, and this positively charged molecule attract it to make it align with the molecule to be able to produce the desired effect. So it is considered as one of the most important features, structural feature of acetylcholine. The next is you have 2 carbon-carbon ethylene chain. Here you have, it is attached to CH. The next here you will see a O, and then you are going to have, an ester. You know the functional group for esters? Esters are usually written like this, R, C, O. R. So this is different with this one. So this is what is here. So you now have an R. So you are having this quaternary atom here. It must be positively charged. Then it is going to be a chain of 2 CH group. It will go through a bridge of oxygen, and then you have an ester group. Where are you coming from? Are you just coming to the class? Huh? Where are you coming from?
Because I think they were the ones.
Okay, who is the person? What was the person that was sick?
She's stable now. She's fine.
Has she been discharged? What is the condition? What is? Come. Are you coming from there?
Yes, sir.
So where is she now?
She's still there.
Why are they there?
They are not connections.
Then you have your CH3. So if this structure NH3 is very, very important for the first. You have to understand the structure, that it contains a nitrogen atom that is permanently positively charged. The next important feature of the structure, which means every drug that must activate either muscarinic or nicotinic receptor must resemble either in one or two aspects of this structure. If anything is missing, then it's likely that that drug will not behave like acetylcholine. That is the importance of the structure activity relationship. So it has a nitrogen group, it has two carbon-carbon chain, then it has a ester linkage, and you have a SI group that is attached. Each group contributes to pharmacological effects. So let us look at the number one, where you have nitrogen ion. Why is it so important? As I said before, cholinergic receptors are negatively charged. So if a drug that is going to bind to a cholinergic receptor doesn't carry a positive charge, it is either going to be a very weak, it is going to have weak interaction, electrostatic interaction. It will not have strong binding force. So the effect will not be so strong. Therefore, acetylcholine with a positive charge then means that any drug that must act on muscarinic or nicotinic receptors will also carry a positive charge. The interaction will help to position the drug perfectly on the receptors. What are the pharmacological consequences of what we have just described? The permanent positive charge make it, number one, it makes it highly polar. When you say something is polar, as I explained before, it means you will be able to distinguish a positive side and what? A negative side. It makes the drug to be poorly lipid soluble. Any drug that carries a charge will not be able to dissolve very well in fats, in protein. So acetylcholine is poorly absorbed in the systemic circulation. And that explains why acetylcholine doesn't have central nervous system effect. It doesn't cross the BBB, the blood-brain barrier. And because it is having a positive charge, transportation of acetylcholine depends on active transport, not passive diffusion. Acetylcholine transportation is by active transport because of the positive charge. So those are just the pharmacological implication of the head being a positive charge head. What is the implication of the C-C bond? CH2, CH2 bond. This one, let us be adding them one by one. This, then the next important thing is CH2, CH2 bond. If you are reading your pharmacology, you will understand that distance, if it is too short, it will not be able to produce a pharmacological effect. Which means the distance between the positive charge and this O must be equivalent to C-C bond. Any change in this distance will make this molecule to lose pharmacological effect. Either it will be less active compared to acetylcholine. But if the distance between the positive charge and the oxygen bridge is similar to C-C bond distance, then the pharmacological effect is going to be very similar. So in any drugs that are used in autonomic pharmacology are compared to acetylcholine in terms of the distance between the positive nitrogen end and the oxygen group. The distance here must be similar. You will see later that if you now substitute anything here, it will give you a different drug with different properties altogether. You understand? We are going to see that later. How the changes affect those compared to acetylcholine. So let us look at the effects now. The two carbon-carbon chain, and the ester oxygen. This oxygen is able to position the drug along the length of the receptor appropriately. I say the distance between this and this is very important to maintain so that the activity is comparable to nitrogen. Because if the distance is exactly like this, it is able to align more perfectly with the receptor. But if we make it shorter, the position of this may not balance with the negative position of the receptor. But if the distance is maintained as here to here, just as you see in acetylcholine, there is going to be an equivalent activity. Any change will either make the drug to be less or behave pharmacologically different. So that is the next structure. The next one is your ester group. This is the ester group, the C, double bond, and O. That structure confers the metabolic properties of acetylcholine, the metabolic nature of the acetylcholine. A change in that will make either the drug not to be metabolized by acetylcholinesterase at all. If we change this, the ester group here is responsible for the metabolism of the drug. So changing this will make the drug poorly metabolized. And making it poorly metabolized means it will have longer duration of action. You know, when a drug is rapidly metabolized now, the action stops immediately. But if you prolong the action of a drug, which means that drug is going to act for a longer period of time. Do you understand?
Yes.
This understanding helps pharmacologists to be able to formulate drugs in the laboratory that has similar activity with acetylcholine or improve on the weaknesses of acetylcholine. Now, acetylcholine as a drug is rapidly metabolized by acetylcholinesterase, as we have mentioned before, and that makes it very difficult to be used in actual treatment because you cannot administer a drug every 5 minutes. How many times in a day? That would be too much. So by improving on this, understanding this chemical and structural relationship will be very easier for pharmacologists to improve on a new drug, maintaining the binding capability and reducing the rapidity to which it is metabolized. Do you understand? So we are going to look at drugs that have been produced by changing some of those molecules. I mean, some of these properties we are mentioning here. This must be there. The distance must be maintained. The O bridge is so important. The ester group is very, very essential in metabolism. So if we introduce something that will change the structure of the ester, it means a new drug will be introduced with the same activity, but it will not be able to act for a longer period of time, making it better to be used clinically than depending on the drug that need to be administered every 10 minutes. Practically, that is not possible. Do you understand? So, yes?
Please, I'm kind of confused. The second explanation, they say the distance between the positive charge and the O, the O must be equal to the carbon.
I said, if we look at the chemical structure of acetylcholine. It has a nitrogen with a positive charge. It is the next thing it attaches to carbon before any other different thing. This distance here, you know. Okay, let me mention another thing. Oxygen has a long pair of electrons and it makes it highly reactive. Understand? It is always willing to come into covalent relationship with another electrophile, another electron-seeking species, so that it will be, as it is here, we still have some electrons that anything that wants can share. It may not give out like electrostatic reactions we do, but it will share. So now, the structure of either muscarinic or nicotinic receptors overall is negatively charged, and it will want to be stable by electrostatically being attracted to this. And for it to be very stable, it must, when we were talking about receptors, we say you should picture a receptor in form of a lock and what? Key. It must perfectly fit in before it will be able to act. So for this drug to fit on a muscarinic or nicotinic receptor, it must position in such a way that the plus will coincide with the most electronegative position on the receptor, and also this will still be within an acceptable distance. As if God was able to, let me say, this is a receptor, and here it has a point that needs to be attracted toward an electron, and it also has a negative position on it. And God was also able to produce acetylcholine, such that if you don't carry this acetylcholine and come and put here, the distance between this where it will attract this oxygen and the position where it will attract to this position correspond naturally with this distance. Therefore, changing this distance either by substituting something here, once you change this, the desire of this species toward electron attracting ability differ from simply hydrogen. So it will distort how these electrons are behaving. And if you now carry that molecule and put here, the interaction between this point and this point, and this point and this point will not be the same again, because we are introducing something that is disturbing the electron distribution. I don't know whether you understand. That is why in the natural structure of acetylcholine, naturally, it aligns with the receptors to which acetylcholine is able to stimulate, because the position where it will be positioned with oxygen interact with the oxygen in terms of satisfying the oxygen molecule. And also, if we not stretch, if the acetylcholine will not stretch itself, the positive position also corresponds with the negative position on cholinergic receptors, making it a perfect match. If you are able to study receptors in a molecular level, you'll be able to see all this. So when we say a receptor fit into a drug in a manner comparable to a key and lock, at the molecular level, they are telling you that when you align the two together, they are able to share electron deficiencies and balance off. That is why they are very stable. They form a stable structure. So the positive sign here is going to correspond with the positive sign on the receptor, while the oxygen is far at a position that corresponds to the same position somewhere on the receptor, such that if you superimpose this structure on this receptor, the positive side will match the negative position While the oxygen will also match a place on that receptor where it is sharing electron with oxygen, making the two very comfortable as if they were naturally the same structure. And that makes it more likely that acetylcholine will produce the type of effect we observe in acetylcholine. Now, if we now bring in a different structure by chemical manipulation and add something here that is able to pull more electrons to it, even if you are lying, this will correspond here, but the interaction here will not be strong again because oxygen is already satisfied with another molecule. So it will be a weak interaction. So you don't expect to see the same pharmacological effect as when it was just hydrogen. Do you understand? Yes, sir. So let us try. So the R here is just a simple CH. No? So this is our typical structure of acetylcholine. Now, if you let us look at what will happen. Now, structural activity modifications. If we want to number this structure, you start here. This is what is called alpha. Alpha position. Then you have beta position. You measure this is alpha, beta, gamma. Alpha, beta. You go to this direction. Who is not following us at all? Can we move?
Yes.
Okay. The first manipulation that have been observed is beta substitution of the hydrogen with a methyl group. Beta substitution. This is beta. So if we now remove this H and put CH3, it will give you a drug that is called methacholine. It's a drug entity. It's a drug that is very similar to acetylcholine. It is either called acetyl B-choline, a beta substitution of acetylcholine, removing an H at the beta position and replacing with a methyl group, give you a drug. Now what happened is has not significantly changed. It behaved very similar. It behaved very similar. But as I said before, all cholinergic receptors respond to acetylcholine. But there are two types of receptors. You have nicotinic receptors and you have what? Muscarinic receptors. Okay. Naturally, when you now change this position and remove that hydrogen and put a CH3, you make this drug to be less attractive toward nicotinic receptor. It will be more activity will be seen more on muscarinic receptors. Do you understand? it will shift, the affinity will shift from nicotinic to more of muscarinic. It will no longer bind to nicotinic receptors. That is, the balance has been disturbed. Although it still favored muscarinic receptor, but it lost nicotinic effect. Do you understand now? Yeah, that is beta substitution of the hydrogen with a methyl group make the new drug methacholine to have only or more muscarinic effect than nicotinic effect. It has more of muscarinic effect, but naturally, acetylcholine balance on the two receptors. It can bind either the nicotinic receptor or it can bind muscarinic receptor. But when you substitute something on beta position of the carbon, the nicotinic will be lost. You will not have only muscarinic effect. That tells you that this distance has been tampered with.
Yeah.
It is still okay with muscarine, but it is no more okay with nicotine. Again, because you have introduced something here, the ability of this drug, it will be less susceptible for alkalosteresis. That is to say, the duration of action of methacholine will become longer than simply acetylcholine by just introducing something here. This gives, what the significance of this is, it gives you as a scientist the ability to manipulate this structure and produce many types of drugs that you can use and test for activity. So just that substitution is able to change the receptor type. It is also going to change how fast it is metabolized, which means methacholine can be used more for clinical purposes than acetylcholine. Acetylcholine is weak, cannot stay for a long time. But when you now remove the hydrogen and put a bigger molecule, what happens is by steric hindrance, it will not be able to be accessed by the metabolizing enzyme again. You know, this H will block it because of addition of a more bulky functional group. You understand? So that will make methacholine different from acetylcholine. Let us keep our acetylcholine unchanged. If we now come to the last group, this group, the last group have a CH3, right? If you remove that CH3 and put what is called a carbamate is an NH2. Usually, this needs 3 to be satisfied. So it is lacking 1. So if you now come here, if you come and instead of that CH3, you come and put NH2. This is what is called carbachol. What you have succeeded doing is, as we mentioned before, that the ester group with this functional group, since it was a simple CH3, acetylcholinesterase was able to, but when you remove the CH3 and put a more resistant, because this N is not easy. Nitrogen has a very strong grip on whatever attaches to it, just like the earth. This will make it completely impossible for cholinesterase to metabolize it. It is not metabolized by acetylcholinesterases again because of the substitution here. And that drug is called Carbachol. Those are the second possible manipulation you can do in the laboratory. The first one is changing hydrogen at the beta position by introducing a methyl group there. Or you can leave that hydrogen at the beta position to be intact, and you now come and change and introduce a carbamate. The carbamate is an NH2 group at the end of that structure. So the difference is acetylcholine is rapidly metabolized, while carbachol is very resistant to metabolism. The implication is you are now looking at a drug that can behave like acetylcholine, but has a very long duration of action, even more than methacholine. One important pharmacological implication of this type of drug is, if you are to experience side effects of this drug, it will also be very difficult to reverse that side effect. Can you picture that?
Yes.
A drug can produce a side effect. If that drug is easily metabolized, that side effect is going to be very temporary.
Yes.
If you not manipulate the structure so that you can retain the activity, but make that drug less available or impossible for metabolism, which means the side effect is going to be very, very long and almost impossible to reverse easily. And in case of overdosage, it may cause a permanent damage in the system. So the more you make the drug less susceptible for metabolism, the action will be longer, and in case of overdose, it can easily result to permanent damage in the subject. You understand?
Yes.
So we look at two manipulations. Manipulation number one, we were able to remove this H and put a CH3. And we were able to get a new drug called metacol, right?
Yes.
So, or we retained the H and came and removed the last methyl group and substituted it with the carbamate, and we were able to get carbachol, which was even more resistant to hydrolysis than acetylcholine. These two you can now do this. So this is what you are going to have. You are going to have this CH3, CH3. You are going to have CH. You have an O, then you have an ester group, you have CH, and this is your typical acetylcholine. So if you remove this and put a CH3 and you put a CH, this is methacholine. You have just changed this. You can also, instead of just this, you can do both here. CH3. Of course, this head is the same.
Yes.
So you have CH, you have CH3, you have CH, H, you have O, you have this, and you have, instead of having this, you have H2. Both the change that gave you methacholine and the change that gave you carbachol is maintained in the last structure to give you a drug called betanicol. Do you understand?
Yes, sir.
So you have, this is the parent structure. Change number one. Just remove the first beta H and replace with a methyl group. you have methacholine. Methacholine was found to be more, the duration of action is prolonged a little more than acetylcholine. And it was found that it is no more attracted to a nicotinate, bound to nicotinate receptor. The activity was more on muscarinic receptor because of the change. If you now leave this intact and only changed here, you have a drug that was even acting longer than methacholine. If you maintain the change at the beta position and the carbamate position, you have a new drug altogether called betanicol. Betanicol has completely lost acetylcholine activity. It's only muscarinic receptor, and it is not completely, it is not hydrolyzed by acetylcholinesterase, and therefore it has no practical position in systemic pharmacology, because if you use such a drug, the side effect is going to be overwhelming, because, as I said, increasingly from methacholine, from acetylcholine to methacholine to betanicol to carbachol and betanicol, the resistance in hydrolysis increases as you are able to change. The implication in pharmacology here is you will be able to change this structure and get a drug, because this one is completely useless pharmacologically because it doesn't last even up to a minute. Such a drug cannot be useful in the clinic because you will need to give, if you give like 20 milligrams of acetylcholine to a human being, if it doesn't act up to 5 minutes, it will be cleared off. But if you don't change anything along this structure, you'll be able to get a drug that can have a better activity similar to acetylcholine, but longer for you to be able to use in the clinic. But when you now change the structure beyond a certain limit, you may have an experimental tool, but clinically, you will not be able to use such a drug again because the usefulness of that drug will be lost, and it will be very dangerous to employ such a drug in human clinics because a drug that cannot be metabolized easily will also be very dangerous in case of overdosage or accidental poisoning. Maybe a child, you just carry it accidentally, ingest more than the required amount of the drug, and you will lose that child. So such a drug will not be useful in the clinic. Structural activity relationship applies to all the types of drug classes we have, and that is how you'll be able to get a family of drugs with different drugs. You have ciprofloxacin, you have norfloxacin, you have what? Ofloxacin, levofloxacin. That is why they are related, but small chemical structural differences gave them different pharmacological activities. One may be acting longer than another one. One will have ability to cross cell barriers more than another one. Do you understand? Yes. So structural activity relationship applies to all classes of drugs in pharmacology. So this is just an example to show you that if you manipulate the chemical structure of an original drug, you will be able to get other sister drugs that may vary in activity and may also produce different types of pharmacological responses. You may either improve an existing pharmacology activity, or this manipulation can even abolish a particular side effect completely. Do you understand? Yes. But as a rule, going beyond a certain limit may produce a drug that will not be useful again because of unwarranted effects that may be dangerous in human use. Any question? Yes.
So does it mean based on this structure activity relationship? Because I was reading a particular time, so is it Lama or this thing, asthmatic, short acting and long acting? Does it mean that it's directly related to?
Yeah, it's directly related to this. You can increase the duration of action. Actually, when a drug is discovered, post-marketing effect will tell us you can improve on certain behavior or characteristics of that drug. You may see, but also, even the duration of action can be of advantage in one area, can be a disadvantage in another one. So it depends on what is presented in the clinic. The clinician will decide, okay, in this patient, let us use a short acting, or let us use a long acting. Or a long acting in most of the time cannot even be manipulation of this only alone. It may be effect of formulation.
Yes.
For example, like oral drugs. If you look at some tablets, you see slow release. Certain drugs cannot be metabolized or be broken down in the GIT until it get to the intestines. That will slow the onset of action. So many manipulations take effect before a final product changes behavior. But primarily, it may be at the chemistry level, or it may be at the level of formulation. If you coat it with a particular substance that acid may not dissolve it, it will not act in the GIT. Which means while it is passing through the GIT, no effect until it passes the acidic region and get to basic region, and the best will burst it and release the active ingredient before you now start seeing the effect. So it depends on whichever method that will preserve the effect of the drug. But basically, structural activity relationship is one of the strongest weapons you can use to manipulate a drug and produce a new drug with improved characteristics. Yes.
If you identify one of the chemical, you do 3 carbon chain.
I do what?
3 carbon chain.
I didn't do what?
Maybe you know 3 carbon chain.
It's 2.
Okay, that was. They're supposed to be this and CH and this. So this can be a very good exam question, isn't it?
Yes.
Okay, test. So our next thing now is we should be able to discuss the drugs and we'll be able to understand their mechanisms and their application in the clinics and all this. With this little idea background we have spent so far, will now help us to understand the real drugs. Do you understand?
Yes, sir.
Yes. So, but for today we are going to stop here.
Yes.
So what we have just discussed, which aspect, who don't even understand anything? Or do you have any question relating to what we have just said?
Methamphetamine, is it that is called carbamazepine?
Huh?
Is it methamphetamine that is called carbamazepine?
No. Methamphetamine, this is the first structure, the parent structure, so acetylcholine. If you just remove this and put CH3, it's methamphetamine. If we leave this intact and come and change here, a carbamate, NH2, remove this and put NH2, you have carbachol. So you can find it in your textbooks. Which book can you find it? You can find it in, I think it's Bertrand Jigazon.
Essentials of medical pharmacology. So yes, sir. While studying for the GS, GI, and GK, you made mention of that the GO is responsible for neuronal activity. While studying, I saw that the GS, after it stimulates adenylyl cyclase CNP, that calcium channels will open, and for GI, potassium channels will open.
Which light do you want to throw on? Or is it I don't believe what they say?
I just can't.
So what is your confusion?
I don't really understand the mechanism. I just crammed it in the way it was.
See, stop bringing confusion here.
Okay, so put it again. What did you cry?
For the GS, I saw after adenylyl cyclase stimulation and calcium channels opening, then GI inhibition, potassium channels opening, then for the GO, so potassium channels inhibition. Thank you, sir.
You see, pharmacology, the level of saying, this is the molecule that is moving to this place to stimulate this one, so that this one will happen is after what is called molecular pharmacology. Sometimes when I'm in a class, I try to avoid, in a class level, I will rather want to stop at the level that the curriculum described for the class purpose, you know, and at the molecular level, if it is not very relevant for the class, I wouldn't want to bring in certain descriptions that may cause some disturbance. So going to the molecular level, why it is potassium, why this one is calcium, is molecular pharmacology. If you are interested, you can discuss that one privately, but it is beyond the level of to say we go to molecular pharmacology. To say that, even to say that a drug is able to open a channel, it is not as simple as mentioned. It doesn't open the way we open a door. There are a lot of things that happen before you. When you're talking about opening of calcium, it talks to the proteins that are involved. Certain proteins have to be increased, like camodulin. You know, it has to be secretion of camodulin. Camodulin will not bind to other proteins downstream. You know, so activation of adenylyl cyclase or inhibition of adenylyl cyclase has to do whether certain proteins has been stopped from being produced. And when such proteins are not produced, calcium itself will not be able to interact with the appropriate proteins to be able to open its channels. But if the right proteins are synthesized, it means potassium also, we have available proteins to interact with to open the channels. So those things are so intricate that if you bring all at the same time, you will cause confusion in some people. And I will also warn you, for the sake of going gradual, locate the correct material. If you are reading a material that is above your curriculum, even if you know it well, you will end up failing that course. It's because it's not because you don't have the brain, it's not because you don't know it, but you have known very well the wrong thing at that time. So how will it help you? If you know the wrong thing very well now, and the correct thing you don't know it, won't you fail?
You fail.
You will fail. So don't be so enthusiastic. Follow gradual. Huh?
So can you suggest material for us?
Hmm?
Can you suggest material for us?
You can buy living course pharmacology. There is the 8th. This is 7th. There is 8. The one I have is 8th edition. Although some of the things I'm explaining here are not in that book.
Yes.
But this should be able to pass you your pharmacology very well. It's very easy to understand. But a lot of things are left out here. It's not that deep. But other textbooks, if you are reading now, they will be too deep for you to understand what you are reading. But as you go later, you read them, you will not understand. So it's good to go gradual, right? So if you get Ripping Cut Pharmacology, if you get Ren and Dare, if you get Bertram G. Kazon, at this time I will not even recommend Godman and G&G, Godman and Gilman, because that one goes so molecular that you still need some good pharmacology knowledge to be able to understand those authors. But this one is very good. And it doesn't cost much. It should be less than 35,000. So, after these foundations, maybe we can have a common WhatsApp group. Some of this, I have some slides actually, but I came the slides. If I have known, I will come with my projector. There are some, even all those receptors, they are diagrammatical. So if you are looking at the diagrams, it becomes very easy to have the picture in your head. So I should be able to send the slides prepared for you.
I'll collect it and send to the
Listen. And then, that should not take the place of making your notes.
Yes.
Make your notes. You can explain it the way you understand. You can even write your note in your dialect. You understand? So that you'll be able to understand it. But if you write your note as I'm explaining, I'm not explaining from one textbook perspective of one textbook, you will get a little more. But I should be able to send some of the slides and the they will serve as a guide.
Yes, sir. Yes, sir.
And you should be able to, at this level, no note should be enough. If I say I will give you a note that will be comprehensive, it will be a very big, voluminous material. So make your note. I will still send some of these slides to you. You can read it on your phone, or you can print it out. Compare with your some textbooks. But try and limit yourself to what we are talking about. And look at your curriculum. So you don't go knowing many things that are higher than this course content now. It will not help you. Limit yourself to the course content now. Pass. If you really love pharmacology, you can go to master's level. You will still do this course at master's level, and they will not just be mentioning receptor, they will go higher. You can still do pharmacology at PhD. They will not just be mentioning muscarinic receptor, it will go higher. Just like computer now, you can do computer in nursery school, in secondary school, but people are doing PhD in computer.
Yes.
So there is stage by stage. Just play along with the curriculum you are using now. Just be able to pass and you go in later. So I will prepare all these slides. I will give you as PowerPoints. So you'll be able to use them for revisions and everything. So when we come back, we'll go into deeper understanding of classes of drug and examples of each drug as we have them in clinical use. So, thank you people so much. And then read that our classmates that is sick. Every one of you will lecture to her so that she will catch up.
Yes,
Who will
sir.
do that? Okay, you do pharmacology.
No, we have like me and Wisdom now, and another person. We are three. We are seeing ourselves in class accountability partners. So she has her own accountability partner.
Fix me up in one group.
Join our group.
So we'll see, and I will arrange for this time. I have things, I don't know. We need to go faster than this. I think the next we are going to see, we will increase the speed so that we can cover more. We have finished most of the conditions. It's just to apply what we have done now, so that we can finish it. So, see you. Yes.